Yeah, thank you very much. It's an honor to be here. Now, I don't know if there's a timer, but I'll try to keep it within 7 minutes. First of all, it's exciting because there's no one to debate against except myself. So it's a debate with the speaker of one. I think, I was worried that it would be something like, cabbage versus PCI for left main. So thank God it's not that debate, because that we still haven't resolved. Okay, so high-risk PCI to MCS or not to MCS, a case-based debate. So I'd like to start off by actually presenting a few cases. This is a patient, an 86-year-old man who was transferred to us. You can see he came in with unstable angina. He's got this high-risk anatomy there. Now, if I can go back and play. So these were actually in Apple. So in PowerPoint, I think they only play once. You can see there's a high-grade osteostenosis on the right, and again, a very complex lesion on the left. So again, 80-year-old man with comorbidities, EF of 30%. Here's an 82-year-old man with a history of SAVR, had a valve-in-valve, and again, he presented with a syncopal episode, was found to have some aortic valve restenosis, and they did a cath and they found that she had a high-grade stenosis. There's nodular calcium extending from the left main to the circumflex. And here's a 79-year-old man who was admitted to another hospital. He actually has bad COPD. I think he's also a veteran, and if I'll go back and go forward again. You can see that the left main is very tight. Here's a graft that supplies the circumflex system. There's a lesion at the touchdown in the retrograde portion. Oops, and then this is his RCA, and you can see the lima is atretic and really doesn't supply much. And his ejection fraction is 30%. So we basically have 3 left mains, 3 patients in their sort of early 80s, late 70s, multiple risk factors, all have high creatinines. And the question is, which one of these patients actually, thank you, you can play those. Whoever's doing that, thank you, you're an angel. All right, so the idea is when do you use a device or not. So before we talk about how we did this case, again, in the interest of time, the case for and against MCS is on this slide. We have the somewhat small font, I apologize for that, but we have the, tried and tested intra-aortic balloon pump, meager support, but sort of easy to use, and we've all been experienced, we have experience with that. Then there's Impella, the family of Impella devices keeps on growing, and again, they have advantages. Overall, you can get somewhere between 2 to 3 liters of unloading of the ventricle. Then there's tandem heart, a little bit more invasive and tricky, and not many of us do that these days. And then there's ECMO for the patient who's truly in dire straits. And so the argument for is in these first two, in the first 2 rows, that there's active unloading of the ventricle. And it's not only, now we're not talking about shock now, we're talking about high-risk PCI. In the context of high-risk PCI, unloading the ventricle stabilizes it, gives you some resistance against ischemia. So when you have these procedures which require prolonged inflations in the left main, multiple sort of atherectomy devices, perhaps shockwave where you have to go multiple times, I think there's an advantage to unloading the ventricle and protecting it, especially if the ventricle is already either proven to have failed once or at risk for failing. The argument against is this, the comorbidities, and these tend to be more vascular and have to do with insertion. So it's not the device itself that's harmful, it's the process of putting the device in and maintaining it. And many of these patients also have concomitant risk factors, such as, for example, PAD, and so they have ischemic legs. And so we've had patients where actually, even before the procedure is done, they start complaining of leg pain, and they're dealing with an ischemic leg. And obviously, for high-risk PCI, the intention is to take the device out once the procedure is done. But again, arguments can be made for and against. The question is, should everyone who qualifies get a device? Well, who qualifies? And so, for the rest of the rest of the talk, I'll talk about the Impella device, because by and large, that's what we mean by MCS for high-risk support these days. And again, I think we're fortunate to have a device that offers us protection, but also we have to realize that it may have some shortcomings. It may not be for everyone. And so what does the data tell us about Impella use in these patients? And so multiple studies have been done, but really the published literature comes down to 2 studies, PROTECT-2 and PROTECT-3, when it talks about Impella in these patients. PROTECT-2 was randomized between intra-aortic balloon pump and Impella. It was an older version of Impella, which actually I think worked well, though obviously not as robust as the CP. And there the challenge was that there was no difference in 30-day composite adverse outcomes. And one of the reasons is the way they defined the outcome. So they actually included they encouraged people to use rotational atherectomy. There was a high risk of peri-procedural MI, and that had to do really with the sort of the troponin leak afterwards and the way they defined it. However, when they went back and looked at the same patients at 90 days, there was actually a signal for improvement for patients who were treated with Impella. And so that was sort of looked at in PROTECT 3, which was actually a registry, but they took out those patients who actually met the criteria for PROTECT 2 but had not been randomized. And so with the caveats that this was a registry, they found that people who were experienced with doing Impella were able to do them, were able to use it a little bit better and get better outcomes at 30 and 90 days. And obviously they took out that sort of perioperative MI definition that they had. So again, some people thought that this was kind of playing with the numbers just to get the result that you wanted. But the bottom line is, for those of us who've been doing complex PCI, there are patients who really, the cases you just could not have done without Impella support. Today. And PROTECT 4 is ongoing, and we're part of that trial. In fact, one of these patients did get enrolled into PROTECT 4, and I'll tell you what happened with him. So the data really doesn't give us a definitive answer. To some degree, it's just in the eyes of the beholder, but I think the argument for this talk is, for the purposes of the debate, that yes, there are some patients who do benefit from these devices. So going back to our patient, we always, after the ejection fraction, like to look at the LV-EDP and the PS saturation, because I'm not so much interested in the anatomy or the ejection fraction. I think we can do fairly complex procedures in both low EFs and fairly complex cases if you work efficiently. My concern is more the reserve of the ventricle. And so the way I measure that in the cath lab is the LV-EDP, just to see what we're starting off with, what the threshold is for ischemic diastolic dysfunction, and then the other one is the PS saturation, which gives me a rough idea of the cardiac output. We do measure cardiac output, but I feel that the PS saturation, if you actually follow that along, is a better sort of real-time assessment of how the ventricle is doing. And so this patient actually was 50. So my cutoff for Impella is about 50. This patient had a PS saturation of 53. And I actually knew that this was going to be a complex case. Also knew that there was no support from the right side. I don't see any collateral. So if the left side goes down, this heart's going down. And so you can see here, we put the Impella. I just want to show you how complex this lesion was. This is a turnpike catheter, and I really just can't get, that lesion is so tight that even a catheter won't go. But once we were able to get that down, we took this sort of hydrophilic polymer jacketed wire, it's Fielder XT, got it down to the apex, drove the microcatheter down. Now remember, this LAD is now ischemic, so we have to work fast. Got in a balloon, sort of a rotor wire there. I actually ballooned this with the 1.5 balloon just to get a channel going. The question then became, how do you do atherectomy for these? And this is obviously a different lecture, but we decided to do provisional. We did IVUS, and we found that this is nodular calcium. This is a slit. This is the eye of Sauron. This is what you have to get through to get this LAD open. So we did not want to make the left main too ischemic. So we went ahead, did sort of aggressive ballooning and a cutting balloon, and then we just went ahead and stented the circumflex, keeping enough of a channel open in the LAD that we could get an atherectomy device down there. And you can see the heart's already kind of looking more comfortable. Some of that comfort obviously comes from the Impella unloading the ventricle. We then went ahead and did atherectomy all the way down the LAD. Again, I like to do high burst speeds, partly because I don't like to dwell too long. There is embolization with these, and you can have drop in EF. So this is what it looks like. Again, IVUS guided PCI, and that's our final result. So ultimately, we went ahead and now we had to address the left main, and for there we chose a tap strategy. We stented from the left main into the LAD, and then actually, it's more like a T-stent because it was left mutility. Anyway, this is the final, and again, Impella supported. Impella came out at the end of the case. The patient did fine, and he left a few days later. The second patient, this is our patient with a TAVR and SAVR. So he actually had syncopal episodes, and as the concern was that he also had atrial fibrillation. He had moderate aortic stenosis by echo. So we really didn't know what was the culprit. The idea of addressing this was that in anticipation of a possible valve procedure, now you can see he's got a fairly horizontal aortic valve. This is not an easy patient to put an impella in. These are the kind of cases where we've had actually TIAs afterwards because trying to get the impella in, it scrapes along the aorta. So his mixed venous was actually quite reassuringly 62, so I did not feel that I needed an impella up front. We could not do an EDP, we did not want to cross the valve. However, his ejection fraction was also in that 35 range. In his case, and this is all going to be in one sort of slide, we went ahead, wired the circum. This is nodular calcium. Again, we had Ivers to show us that. I find that nodular calcium works, atherectomy works best for it. I think it cleaves the calcium, then you can do aggressive ballooning. You can see there's a bit of a waste there. And this was the tricky part where you had to do IVL, so we used a fairly large size balloon. And one of the things I like to do is take a break, and sometimes we'll do a saturation check between IVL runs just to make sure we're not suppressing the ventricle too much. Ooh, I don't know what that is. Maybe you can go forward and then come back. So let's go back one, see if it plays right at the end. I think it's a conversion from the, but trust me, it was a beautiful result. It was fantastic. And again, we took the device out. The third case was a patient who had that failed Lima graft, and again, failing grafts here. The right side was supporting us, so there was that confidence. His mixed venous was 59%. With the EDP of 12. So he was really well optimized as his heart failure. So in his case, he was our Protect 4 patient, and we were ready to use the impella. He got randomized to a balloon pump. In fact, if you can go back, I'm going to start this again. What had happened is in the 2 or 3 days it took us to randomize him to Protect 4, look at what happened to his left main. His left main shut down completely. So that truly was the culprit lesion. We wired it, we angioplasted it, got a good result there. There's a bit of a dissection in the left main, but you can see that, we still have a channel to the circumflex. So this is, again, using sort of a high definition mode to get into the circumflex. And then we sort of completed the PCI with the reverse culotte. And hopefully you can see the final result there. And this was done with the balloon pump. Sometimes you will see myocardial suppression. You see loss of pulsatility, It's not a big deal. I think if the ventricle is compensated to begin with, you just wait to do the next inflation, let the pulsatility come back up. Now, if the pulsatility does not come back up and the mixed venous is dropping, that's when you want to think about putting an impella in if that was the plan. Okay, so to summarize the case for MCS, I think the real question is not whether you need support or not. The question is, which ventricle needs support, and trying to figure that out. And so all high-risk PCI is not the same. So the question is, how do we define risk? And I think that's what's important. Just looking at the ventricle alone, the EF or the anatomy is not, I think, a good enough marker. They're not accurate enough for determining risk. I think you have to have additional considerations. Chronicity of the low ejection fraction. Obviously, if you lost that EF recently, that's a little bit more troublesome than someone who's compensated for many, many years. Pulmonary status, are they doing have ongoing pneumonia, PE? Sometimes that can compromise your ongoing lung disease. Hemodynamics, vascular status, you want to know what their arteries look like, whether you can conveniently put a device in or not. And ultimately, the interventional strategy. If you're going to go in, crack the calcium, put a stent in, not as stressful for the myocardium as opposed to taking nodular calcium, atherectomy, cutting balloon, IVL, then doing a two-stent strategy. That's much more stressful for the ventricle. And ultimately, it's trying to get on a boat to take a trip across the body of water. It depends on the body of water, but also depends on whether you know how to swim or not, and more importantly, what the weather is like and how choppy the water is. So you have to really customize it, whether you need a life vest or not. So finally, these are some of the other criteria that I would encourage you to look at when planning these procedures and deciding when to use support. I think, obviously, this is a lecture in itself. And so to the answer of the question, high-risk PCI to MCS or not to MCS, my answer is yes. All right.